Thank you for the introduction, and thank you for the opportunity to speak to you about understanding your genetic results. So we always start out by outlining what we're going to talk about, and we'll get into it. So we'll go over some terms and different things that you may have heard, looking at actual examples of different genetic testing reports. We'll talk about what sort of changes can happen to the DNA, and when you get there's 5 different classifications of genetic changes, from troublemaker to non-troublemaker and some things in between. And then we'll talk about, well, what do you do once you get them, and how they can impact treatment and management, which is a beautiful bridge to Dr. Nichols' talk, who just ended. So she did a wonderful job. If you were present for that, great. So there will be a little bit of overlap. All right, so when we start talking about genetics, not everybody who comes to my clinic knows what a cell is, what a chromosome or a gene, etc. So when we think about it, this illustration here shows you from embryo development where 2 cells become one and start dividing, and those are just examples of different cells and how things grow, which will be pertinent to later in the discussion. The second image on the right side showing you all different types of cells that exist in the human body. And when you look, you see those little dots in the middle. We're going to pay attention to those dots because that's where most of the genetic information is. So when I crack open a cell, I see all these little packages inside, and those are called chromosomes. Human beings have 2 copies of every chromosome. 2 number 1s, 2 number 2s, so on and so forth through number 22. And the last are the sex chromosomes, which are XX or XY, most oftenly for female and male respectively. Then you see the chromosome itself, I explain it like a ball of yarn. And if I start unraveling it, then you can see the DNA, and that's stretched out. Then what you see inside these segments called genes, genetics has a 4-letter alphabet, which are made up of these nucleotides. So the name of them are listed here, and this will become important for the interpretation of the genetic results. Do I need to mom the voice any harder? Do you guys need louder? I can do louder. All right, let's do it. Clean your room. No, just kidding. Yeah. So what happens is the genes here are the DNA, the blueprint. Your blueprint has a job to get read to create a protein, which has a specific job in your body to go do something. When I say protein in this context, I'm not referencing a dietary protein or something that we consume nutritionally. This is on a molecular level. So here we go. Gene is the segment of DNA when we unravel that ball of yarn. And 2 copies of every chromosome means 2 copies of every gene. This is an allele, and this is an allele. So each copy, that's what that word is if you've ever heard it. And then the protein, like we said, is not dietary, but on a molecular level, you make all these proteins to go do something. Go to the heart and create the muscle. Go to the brain and make that neurotransmitter. All of them have different jobs. So when you break down and go back to biochem class, proteins are made from building blocks called amino acids. There's 20 different types. There's essential amino acids that you've heard of. And each amino acid is coded for by 3 DNA letters. Remember that 4-letter alphabet of A, T, G, C? Those combinations, so I have an A, T, and C, that's going to make an amino acid, for example. So there you go. That's what it shows you. So there's the protein that's supposed to go do a job in your body. 3 nucleotides encode for an amino acid. You still with me? We got the train going? Okay. That's what I learned in biochem, is all of these different letters. This could be a T. So don't pay attention to the U. Don't let it throw you off. Pretend those are T's. But you see the different combinations. Then you make an amino acid like phenylalanine, leucine, histine, arginine, etc. So a 4-letter alphabet, take 3 of them to make an amino acid. Then I get a bunch of amino acids to make a chain that's a protein. Still with me? Okay. If you remember from Dr. Nichols' talk, she talked about the first genetic test called a karyotype. That's what this is, right? There's 2 number 1s, 2 number 2s, so on and so forth. This picture of chromosomes, I like to use analogies a lot, is like if you use Google Maps, the karyotype is saying all the continents are there, all the pieces are there, and then we can zoom in and look at higher resolution of your genetic material. So let's zoom in and unravel that ball of yarn. So when I'm unraveling that ball of yarn, you could see the DNA structures here, where it looks like a boxcar, a train, if you will. Here's where we carry the coal, here's the linker, here's some more coal, linker. The reason that the term exon is important is you maybe heard of something called whole exome sequencing. That's the origin of the word. Whole exome sequencing is looking at the higher action portion of the gene. Exons are the coding part. So it's going through reading your DNA. It gets real complicated. It wants to read this, but let's cut this out because it used to be thought of as junk DNA. And let's get rid of the junk, and smack them all together to go from DNA to RNA to get ready to be read and become protein. Still with me? Okay, so that's just another picture of exons and pieces in the middle. This is showing you the different letters of that 4-letter genetic alphabet and saying, well, what if there's a change from a T to an A or a T to a C? That sounds like a possible genetic mutation. So let's talk about that a little bit more. So the types of testing, karyotype, that's the one looking for continents. Microarray is like, all right, there's North America, there's the United States. I'm going to go to Colorado because I'm biased, and then down to Denver on this street. That's a higher level of resolution to look at the same material that can tell you if there's extra or missing pieces of DNA. As Dr. Nichols mentioned, that might be a first-line test that comes across, but it's not complete and it's not everything. I could say that about every genetic test. It's not 100% complete and it's not always everything. So then single gene testing, that was about 15 years ago, the way to go, and the only thing we really had was going one by one. Send one, wait about 2 months for results, send another gene, wait for results. I've been around that long. Okay. So then we introduced the next generation sequencing panels, which were quicker and looking at hundreds or thousands of genes at a time as opposed to one by one. The expansion to that is whole exome. That's where it goes through and reads those boxcars, the money end of the gene, if you will. And it's just reading those coding parts because we thought the stuff in the middle was junk. It's not. We'll get to that. So that's where whole genome sequencing comes in to read not just the boxcars, but we used to think was junk, introns, looks through it. There's differences of resolution for everyone. You could see exome looks at 2% of total DNA, those little boxcars, but that's 85% of human disease lives in the exon, so it makes sense to look there, and if you don't get it, go bigger. I'll use this opportunity to say the increase in yield to go from exome to genome is only about 5% increased yield and diagnostic capabilities. So not a huge jump, but it's something. Variance. Variance can mean a lot of different things, but is reflective of any alteration in DNA from what is, I'm not going to say the N-word, what the majority of people, not normal, what most people have. So genetic variation is what makes us unique. I tell everybody, we share 99.9% of our DNA. It's that much why we're not twins, essentially. But within that, that's about 5 million unique changes why you and I aren't identical twins. Those numbers blow my mind. I think it's pretty cool. All right, so when you have these changes, I said there's 5 types of results from troublemaker to non. So the scientific way we say it is pathogenic or disease-causing troublemaker, likely pathogenic, variant of unknown significance, we don't know either way, likely benign or for sure benign. We've seen it. We know it's not a troublemaker. Okay? the word mutation is going out of fashion, and I kind of like that. The first time somebody asked me and said, "So are you calling my child?" "Nope, let's use a different word." So I say genetic change or difference, which I think sounds better. All right, so different types of pathogenic changes. Missense. Take a look at what the expected DNA blueprint is here. Everything's good. These three make this amino acid, methionine, lysine. Hold up. If I change this G to a C, which is often a spontaneous, just happens spontaneously. I'm going to say it again in the back. Nobody's fault. Nobody can induce those changes. They just happen. So you're changing the amino acid from alanine to proline. So that can disrupt gene function. So missense is something you might see or hear about in your reports. Those can cause the gene to not work at all or increase function. It can mess with it a lot of different ways. Another type of genetic change is you're going along, reading your methionine, your lysine, and here's another change that looks like a missense, but what you notice is that it doesn't keep reading through like the last one, right? These guys kept going. Even though this changed, you keep reading your blueprint. Here, it stops. So that's where you might see the word termination, or it doesn't complete making the protein. And at first glance, that sounds more severe to me as no protein versus continuing making some. So just thinking about that. So this one gets tricky because you can have all kinds of deletion. Itty bitty, a couple letters, the whole chunk. Shoot, the whole chromosome could be missing, right? Getting bigger and bigger. But here what we're talking about for these types of changes is if one letter gets knocked out. You're going along reading, right? A, T, G, A, A. Oh, I'm just going to skip over and pull this T over here. So it changes the rest of your sequence. So usually it can also have that stop signal where you stop making protein. So here we go. I like this. This makes sense to me. Tell me if it makes sense to you because I use it with patients all the time. So one letter change and you keep reading. So if I change the car was red to the car was hat, that's not the same message, right? It's beyond one letter, you could change a whole word. But here's the example of changing one letter. When I think about nonsense mutation, the one where you stop making the protein, you don't even finish your sentence. We just talked about deletions, where if you delete the word car, that really changes the meaning of the sentence. Same analogy within your genetic makeup. So the one we didn't talk about yet is insertions, where some of those 4-letter genetic alphabets get inserted, can stop the reading, okay? So the car was red. If you insert a hat, it changes the meaning. So, all right, those are the examples. Oh, yeah, not just take away, you can add extra. There can be insertion of extra letters that can also impact the gene function and being read as a blueprint. Okay, how are we doing on time? Doing all right. Here is a test report, and I'll show you several other examples. When we look at a test report, the things we're looking at, sample type. Back in the day, most genetic testing was done on blood. Now we can do cheek swabs for almost all forms of genetic testing, which as a pediatric practitioner, my babies love that. Way better for them. But what I want to say is that the quantity or quality of the sample is the same. Blood to saliva. There are some instances where blood will give you a better read. And if you have those questions, ask your practitioner what makes the most sense for us. Then you can see the terminology can get confusing because I think of positive as being a good thing. I want a great result. But here, the word positive means we found something. So to have a negative genetic test result means we didn't find any changes. To find a positive result means we found something. So here's where they say we found one change. That's a troublemaker. in this gene called this. One change in this condition that's called this. And then they found another change. So when you're going through the different columns, there's the name of the gene. There's the address on the house, if you will, that tells where in your DNA it lives. We'll talk about what C's and dots and G's and greater signs mean in a minute. And zygosity. We have 2 copies of everything. That tells me if it's on one copy or on both copies. Then that classification is those 5 types from troublemaker to non-troublemaker. You can see one in the middle is we don't know, uncertain significance. Has anybody seen a test result like this? Very good. All right, so as I mentioned previously, name of the gene, address, that tells us if it's on one or both copies. And we're paying attention to pathogenic and likely pathogenic and thinking of them as troublemakers. All right. Yeah, so when it says heterozygous, that tells me one copy. When it says homozygous, that means both are impacted, both copies. Great question, thank you. Yeah, you guys raise your hands if you have questions as I'm going along or need clarifying points, and also at the end, that'll work too. Okay, so here's some examples of missense variants. There's an amino acid at this exact spot that got changed to a different amino acid. How can I say that a couple of other ways? So we'll walk through what the P and C dot means, because these are saying the same thing, even though they look different. Same thing with the nonsense. When you see the X, that's when you stop reading and don't make any more protein. And then you can see here at spot 1,154 through 85, that had me lose 32 of those alphabet letters. I know it's getting confusing. It's like a semester of biology in half an hour. So here's what the C's and P's and everything means. When I see C, that means coding DNA. Coding DNA dot. So that tells me at this specific spot from a nucleotide perspective where it's at, where an adenine got changed to a guanine. So if amino acids are 3, right, they're 3 nucleotides big, then that means 1345 divided by 3 will equal 444.8. So this is the protein version of saying what the DNA is, right? To become the protein to go do a job in your body. So that's what this is referencing, is here, since changing the nucleotide here, that changes your amino acid from phenylalanine to tyrosine. Confusing? A little bit. We can go over it again. Okay? Other terminology, when we talk about 2 copies of every chromosome, this is that anatomy picture of chromosomes. The top part of the chromosome is called the P arm. P is for petite, because it's usually smaller. Then there's a constriction in the center of the chromosomes called the centromere. And then they said, let's call this arm Q because the next letter in the alphabet after P is Q. That's how they came up with that. Clever. Yeah. Zygosity. That's what your question was exactly. So how many copies of the gene are impacted? So in autosomal, that means one of the non-sex cells. So not on the chromosomes, it's not on the X and it's not on the Y. Autosomal means it's on chromosome 1 through 22. Which one? They'll figure that out. And with 2 copies of every gene, a dominant condition, you just need 1 copy impacted to have the condition, like Dravet syndrome, like SCN2A related disorders, like FOXG1 related disorders. Those are all dominant. Then there are some conditions where both copies of the gene have to be impacted to have the disorder. Where you can see here on the right, Dad has 1 copy impacted and the other working. In those recessive conditions, having 1 functioning copy is enough to keep you healthy and not show symptoms. Same thing with Mama. No symptoms in her, but 25% of the time, they're going to pass both non-working copies. So when you have a child like with Batten's disease, which is recessive in nature, parents are likely carriers, and there's a 25% chance to recur in each pregnancy. It's just like each time, it's not if I have one, then the next 3 will be unaffected. It's with each single pregnancy that's the type of recurrence risk we're talking about. Okay? So, dominant, recessive, autosomal means non-sex chromosome. Then you have X-linked, which means due to a disorder on the X chromosomes, which is one of the sex chromosomes. Females having 2 X's and males having 1 X can affect that differently. Sometimes in some disorders, but PCDH19 doesn't follow those rules, but others do. So there's this process in folks who have 2 X chromosomes. You don't need them both turned on, right? That's how dudes live, is with 1. So those with 2 X's, you just kind of quiet one. So what if one of my X's has a change and the other one doesn't? The body has this random process of turning off one of the X's because you only need one on to live, and it's called X inactivation. It happens in all people with 2 X's. What happens is, what if most of the ones I turn off are the working copy and I'm left like this? That's unfavorable skewing to the affected X. Versus what if more of them are the working X? Then maybe my symptoms are minimal. Okay. All right. So there's the 5 types of classifications we talked about, from not troublemaker to troublemaker. All right. Did you know you have about 22,000 genes that make you you? And I say about because we even haven't settled on that number. So when you think about it, and why genetic testing is important, is this is an evolving, dynamic field. Like Dr. Nichols said, 5 years ago somebody got a test and then they called me with an update. That's what's happening. So if your testing is negative, non-diagnostic, that's not a forever and always. What's happening is, if we only understand about 1/3 of them, we're going to figure the rest out eventually. Everybody's okay? Great. So, there's more to learn. Things are evolving. I said 5 million. That makes us not twins. You know, numbers. So we'll figure that out. The other thing is, folks who are not of primary European ancestry tend to get more of the one in the middle, the uncertain. And that's because when you take the DNA, you're comparing it to what's typical. Well, if most of my database has individuals of European ancestry, then folks who are Asian, Black, Latino, you get more uncertain results. And we're working on it for better representation in our databases, but that's just a fact of how things are right now. All right? All right. So we talked about the classification. What I say is it's a really long process of interpreting. So you see things like variant of unknown significance or pathogenic. It's really a long checklist. Like, what do the computers predict if it messes with the gene or not? What do we know about the gene itself, if it's turned up, gain of function, turned down, loss of function? And then there's job security for us, because you need clinical interpretation. The lab is wonderful, powerful, and amazing at what they can detect, but you got to put it together with that little beating heart that's looking at us in clinic. Does that fit? Does that make sense? Is the caudate small? What's going on? Is there a movement disorder? So it's the clinical correlation that's also super important and part of the process. All right, let's see. So this is showing us another test result that really goes into the details of what the troublemaker change is. It tells you what symptoms are present, and what's important to remember, especially when I talk to my parents of infants who are diagnosed, is if there's a list of 20 symptoms, that does not guarantee you're going to have all of those symptoms. Even in the same family, 2 people with the same genetic change may not show the same sort of presentation, even one who has epilepsy and one who doesn't. So you have 22,000 genes interacting, and we're talking about a change in one. That's why you can have intrafamilial variability. Okay? So microarray, we talked about that test as well, and it talks about the copy number changes and its unique ability to say you get half your genetics from your ma, half your genetics from your pa, if you will. What the homozygosity says, is there close biological relationship, say if these individuals had shared ancestry or came from the same small village in a region of the world where there's not a lot of genetic variability? The strength in genetics is that everything doesn't look the same, that it's a little bit different. And so when the information looks too much alike, then you can have an increased risk for those recessive conditions, but not all the time. There's always a caveat to everything I say. Just put a little asterisk at the end, please. But that's what that tells us. So when I counsel for microarrays, I say it can tell us one of 5 things. It can give me a result. It could come back non-diagnostic. It could come back with an unclear result, which we've talked about. But the microarray can also give us unexpected or incidental findings. I'm sending the test to try and understand why you have epilepsy, but it comes back with the deletion of a breast cancer gene. We have to talk about it and what that means for you and potentially other family members. So incidental finds. The other thing with how similar the genetic information is, this test can reveal if biological parents are blood relatives or closely related from a genetic perspective. The medical term is called consanguinity when individuals have shared ancestry, like cousins or something like that. So, if something is labeled a troublemaker, does that tell me how severe the patient is going to be? Well, yeah, sometimes, but not always, right? 22,000 genes, we're talking about one gene and how that can impact things and how there can be variability even within families. So it just depends, and I encourage you to ask questions if you have questions about your results. Okay? All right. So, yeah, frequently asked questions. Why did this genetic change happen? About 10% of the time, they can come from the sperm or egg prior to conception in an asymptomatic individual. I'm going to say it again for the people in the back. It's not your fault. What did I say? It's not your fault. Even if something is inherited, I look you in the eyes and say, did you pick your parents? Me either. Did I pick which egg I was going to give? Nope. I wanted them tall like Uncle Jimmy. I didn't get to pick that, nor did I get to pick the spontaneous change or inherited change. That's really important because many, many families in clinic carry that question silently or outward. It's not your fault. Thank you. Right? So, if somebody has a brand new change in the patient that's not inherited, Dr. Nichols touched on this as well, is there's a small chance the genetic change could exist only in the eggs and sperm of the parents and not manifest. That's why we never say your recurrence risk is 0, even if it's a brand new change in the patient. It could be in the reproductive cells. We don't test for that. We don't have a mechanism to go test every egg. That would not be good. Or to test the sperm beforehand. Okay? So what if we get one of those unclear results? And often people are like, why do they even say anything if you're not sure? And I'm like, man, telling me. But it is important because sometimes that clinical correlation comes and we're like, clearly this is what it is. The patient has the symptoms. It's in a spot that could be a troublemaker. That's really important. But one way to interpret, and often why testing on the bigger, like the whole exome that we send the trio of mom, dad, and baby, is because I don't want to test mom and dad. I want to use you to interpret your child or the patient's results. I shouldn't say the child, I should say the patient's result. Each parent that participates in the testing increases the diagnostic yield by about 10%. We can do the test without parental samples. It is possible, especially families with adoption and foster situations, etc. But each bio parent helps with that interpretation to say, what's normal human variation in your family versus troublemaker? I think I'm at time, but you got to speak too. All right, so if testing is negative, there's always more testing. You don't have to. But if you're looking for answers and are in the clinic, that's probably why you're there. There's always going to be more testing. There's always going to be advancements. We're at 8,000 out of 22,000 genes. There's always more progress. There is a thing as testing fatigue, diagnostic odyssey fatigue. It's okay to take a break. Your DNA is going to be there always. So when you're ready, we're here to help you and support you. All right, so once you have the diagnosis, now what? We talk about things like prognosis, recurrence risks, but what about activities of daily living and living my life? How do I incorporate my medications and their side effects into my daily routine? Who you share the information with is a personal choice. I say in the academic setting, I see it to be helpful, but I also hear parents who say, I don't want my child labeled or treated differently because of their diagnoses. But if it impacts their activities of daily living or how they learn, you might consider sharing. We also talk about it's your right to share with family, friends, etc. Those are very personal decisions. But if there are recurrence risk things, you might consider sharing with family. And we also serve that role if, relationships aren't great, to help with communication, things like that. I think the family parent advocacy groups should be a part of your care plan. Even if you're introverted and you don't do great with crowds and all that stuff, look outside this room. It's amazing seeing everybody together. There is power and beauty there. So even though I say it's not for everybody, it's a powerful resource. Also, when you're being seen, there's always upcoming treatments and therapies that are evolving, especially precision medicine-wise for these rare epilepsies. Ask, find out, see what's available if there's other treatment options. And then recurrence risks. If this is something with a 25% chance to recur, 50% chance to recur, ask that for family planning. What can we do? All right, so I think Dr. Nichols did a great job to think about who's a candidate for testing. I think diagnosis, treatment, prognosis, and recurrence risks. Those are the big four I always want you to get out of genetics clinic. Yep, talked about screening, intro, microarray, panels are great, exome sequencing is the deeper dive. And, for patients with epilepsy, the range diagnostic rate they have listed is between 15 and 40. Sometimes people, I think of those numbers as 50% likelihood, 70% based on the specifics of certain people's presentations. So that's important to discern. So why does it matter? There's publications on this that talk about what does this do for you? Some people need the peace. I just got to know why. I got to have connection. I want to understand more. There's lots of different reasons and ways that this impacts you, right? Emotional responses. Some people can feel that blame and blame themselves and kind of a sadness and a period of grief, right? Especially if someone's diagnosed very young and you read those 20 symptoms that might not apply to your little one. Those are hard to take. So the point of that slide is making sure you give yourself grace and some time for your responses and how things impact you and your family. So I'll give you a minute to look through some of the quotes from families and how it impacted them. I'm going to give you a 5 Mississippi. Yeah, there's that word, guilt. That's where we talk about different ideas. So, pardon. Resources, things to look at. So I'm going to pause here. Dr. Park, I think your slide is coming up. Oh, no. I did the whole thing. I didn't realize we had that transition. I am so sorry. I thought we were at that mark. My apologies. She's the epileptologist in our neurogenetics clinic, and we had a slide where we were going to hand off. I messed up. You should have grabbed me. I'm sorry. So with that, I want to thank you guys. I apologize for the oversight, but thank you for your time, and let's open it up for questions.
No, they run the whole test. And so we do certainly have patients who have more than one diagnosis, where they may find a main issue, and then they may find something else that they're less certain about that may have some impact. We're just now, as Dr. Saenz said, we aren't just one gene, right? We're 22,000 genes. So we are now starting to understand how different genes can act together. So there's some evidence that say for SCN1A, for Dravet syndrome, that severity can be predicted by variants in other sodium channel genes. And so variants in SCN8A or SCN2A can impact how severe the SCN1A problem is. And so I think that is just beginning to develop, this understanding of how variants in other types of genes can affect the main diagnosis. So they run the whole test and they'll look for everything, but as we said, we don't know all of the genes and what all of them do. Once they run the whole thing, though, they usually, except for a few labs, don't continue to run it. So if something develops that you didn't know about before, they won't automatically tell you about it. So I think it's at least good to kind of, as we've been saying, revisit with your physician and say, hey, has anything new come about? Did we understand any more about this one thing that was kind of at the bottom here that we didn't talk about, or what have you?
I think if you have a clinical presentation and you have the answer in front of you, the reason to pursue additional would be if there's a new onset symptom that's not explained by the present diagnosis the majority of time. I will say about 1 to 3% of patients can have a dual genetic diagnosis, but that's usually under the premise of everything doesn't fit under FOXG1. There's something else. Like if there was something cardiac going on, then I would think about more genetic testing, for example. Great.
Other questions? Oh, yeah. Yeah, I think you should always visit with a geneticist when or your doctor when there are new things that develop. And then maybe what they might be able to say is, hey, because this gene wasn't known about very long ago, we didn't know what people looked like when they were 20 because we only discovered the gene 2 years ago. But now it's 20 years later, and now we know we've looked at a bunch of other people, and we've found many people with your condition, and we've seen some that are 10, and some that are 20, and some that are 30, and we've published all of that. And so now we can look at you and say, okay, so you came when you were very little, we didn't know a lot, and now you're 20, and now we know. We know what 20-year-olds look like, we know what 30-year-old looks like, and we can tell you that those symptoms kind of fit in with what we would expect for this condition after that much time. Or we can say, hey, we learned all of this, and these are symptoms that we didn't anticipate, so let's think about whether we should do something else. But, over time, we tend to kind of test older people. We used to say that this was kind of confined to pediatric fields, but the adult world has the same genetic yield for testing older adults, especially if their presentation of epilepsy began in pediatric years. And so now we're testing people who are 50 and giving them a diagnosis that we just figured out, 2 years ago. And that's very helpful because then we can say to that family with a young teenager, hey, this is what might happen in the future. This is how things might change over time for your sibling or your child. Yeah. Yeah, I think that's pretty tough. As I mentioned, I think we're only cracking the surface of how all of our genes work together to make a whole human being when we have a main diagnosis. So I'd say that's going to be a while before we figure that out, especially because the more variation you have, the more people you need to study something to exclude just background levels of variation from the picture to kind of reduce the noise of all of that. So in order to figure out how all of these different genes add up, we need thousands and thousands of people. And many of these rare epilepsies and genetic epilepsies just don't have those numbers for us to be able to figure that out. And so that's why it's become a bit more challenging for us to do that. I will say that sometimes over time, genes that are initially thought to have only a recessive presentation can sometimes later develop a dominant presentation that we learn about that looks a bit different. So maybe the recessive presentation is very, very severe and has a whole bunch of other things, and we just didn't really know that it could cause symptoms in a dominant way. And so we learn about that, 10 years later. And so those carrier things may become important. And again, why we would suggest that this is an evolving process, and you go back, to the geneticist and say, hey, did you learn anything more about these other things that were on the bottom of this report? Do they have more significance than they had when we came to see you the first time?
that's a very, very challenging question because insurance is not my favorite either. But one thing that comes to mind when I hear you say that is something that could be thought of as a symptom sometimes can be used as a diagnosis to help. For example, the word microcephaly. I think of it as a symptom of something associated with different conditions. But if you use it as a diagnosis, that might help. Other things like autism spectrum disorder or intellectual disability can help. But that's another reason why people want the genetic testing is for that black and white diagnosis for access to care. So I hear you, and you're singing what all of our families say is insurance. A lot.
Yes, that's like the opposite, right, of what we're saying. You can get a specific diagnosis that helps you, but you're saying the less specific diagnosis that's more known can help you get access to things. Yeah. Sure. Mm-hmm. Mm-hmm.
Where it's not an official cerebral palsy diagnosis, but it presents as that, we need to treat it as that. So almost being on the broad spectrum can sometimes actually help.
Yeah, like the autism thing too works in that way.
Awesome. Well, thanks so much. We'll be available outside because I think we want to switch over to the third talk in the genetics series. So if you have more questions, we'll be outside. Thanks.